Welcome to the National Association of Health Unit Coordinators webinar, Inside a Pandemic, sponsored by Froedtert and the Medical College of Wisconsin. My name is Christopher Anderson. I'm the staff educator and a manager for the Health Unit Coordinator Department of Froedtert Hospital. The National Association of Health Unit Coordinators was founded on the values of membership, education, certification, and stewardship, and promotes the health unit coordinating profession through those values, as well as complying with the standards of practice, standards of education, and a code of ethics. Froedtert is honored to be one of 2 institutional providers in the state of Wisconsin for the National Association, and as such is privileged to host this annual education offered to further that knowledge, but also facilitate the continuing education of healthcare professionals, including health unit coordinators. Mainstream social and independent media have focused their COVID coverage on medications, masks, and mandates. Today we're going to look at a couple other angles to this pandemic. With us is Ann Dressel, Director of Global Health and Equity at the University of Wisconsin-Milwaukee, Eric Connolly, Executive Vice President of Froedtert Health and President of Froedtert Hospital, and Greg Engel, Director of Planning and Preparedness at the Wisconsin Emergency Management. A few notes. We'll be taking some questions after the presentation, so please hold on to them until then. If we don't get to your question now, we will offline. We'll be taking some leg stretching breaks between our panelists. The websites for our presenters, as well as NAHUC and Froedtert Health, will be displayed at the end of this webinar, as well as the application information for the CEUs. So without further ado, Ann Dressel.
Okay, and now my slides are not progressing. Let's see. Oh, I'm very sorry about this. Let me try stop sharing and coming back in. Okay. Go. Very sorry. So this is what we're going to talk about in this session. First of all, I'm going to go over some general terminology about what is a pandemic, what is an epidemic, what does endemic mean in the plague. We've all heard of that one. We're going to talk briefly about the global population. As we look back over time, where were we when these pandemics were happening and where are we at today? And then what is that impact on infectious diseases? So the main part we're going to do is take a look back at the 10 worst pandemics throughout history. And when I say worst, I mean in terms of the number of people who died. So we'll be starting in the 2nd century AD, coming through to the Black Death, and then up to the HIV/AIDS pandemic. And then also drawing some connections between what can we learn from history with the current COVID-19 pandemic. We're also going to talk a little bit about the United Nations Sustainable Development Goals. Many people here in the US haven't heard about these, but they can really inform a coordinated global response to things like COVID-19. And finally, we'll close with a little bit of information about local global health resources that are available if you want to learn more. So first of all, what is an epidemic? And I'll see if I can move this out of the way. So as the slide notes, it's an occurrence of disease that is temporarily of high prevalence and that is confined to one region or one part of the world, such as a single country. So you can see the graphic here on the map, and the yellow area shows an infectious disease outbreak. And you can see it's confined to just as one specific region. And in the example they use here, it's northwestern part of South America. Oh my goodness. It seems like when this bar comes down, my screen stops sharing or stops going forward. Oh. Oh, I'm very sorry about this. Okay, we've just come through a few slides. Let's see if we can go back. Nope. Okay, so I'm going to talk through these. We did epidemic, and so what is pandemic? So a pandemic is defined as an outbreak of infectious disease that occurs over a wide geographical area, and that is of high prevalence, generally affecting a significant proportion of the world's population, usually over the course of several months. So a pandemic arises from an epidemic. And the difference between an epidemic and a pandemic has mostly to do, or primarily has to do with scale. So the plague, that's a term we've all heard and which sometimes people use to describe a serious pandemic. You know, they'll use it very informally and talk about the plague, but it has a specific definition. The plague is an infectious disease that's caused by a specific bacteria, and it's the Yersinia pestis bacteria, and that's usually found in small mammals and their fleas. So the disease is transmitted between animals via their fleas. They're biting infected animals, and then that's biting other animals, and they're getting infected. And it can also be transmitted from animals to humans by fleas. And so that's what's known as a zoonotic disease, something that's spread from animals to humans, which is what COVID-19 is. And we'll be talking more about the plague shortly. So endemic is another term many people have heard of. We've talked about epidemic, we've talked about pandemic, we've talked about the plague, but what does endemic mean? So an endemic disease can be described as the constant presence of a disease or infectious agent within a given geographic area or population group. And it may also refer to the usual prevalence of a given disease within such an area or group. So the slide that I can't get back to, it shows where malaria is endemic throughout the world, which is in much of parts of sub-Saharan Africa, in South Asia. It's an infectious disease that's constantly present among those populations in those areas. And I work with a research group in Malawi and Kenya where malaria is endemic. So it's where on average people get malaria about 5 times a year. It's like what we might think of as a common cold. And there's different strains of malaria. Some are much more deadly than others. But malaria is a vector-borne disease. So that means it's transmitted by a disease vector. And in this case with malaria, it's mosquitoes that spread it. So the slide I can't get back to has 3 images showing the difference between endemic, epidemic, and pandemic. But just to reiterate what that means, in a disease that's endemic, as we just said, is something that's constantly present in a specific population. So it might be in many different parts of the world, but it generally isn't spreading beyond those areas. It's just something that's always there. An epidemic, as we said, is an infectious disease outbreak that is like flared up, but only within one specific area of the world. And then for pandemics, that's something you're going to see that is spread all over the world. So it's an epidemic that just has, it's jumped international borders and it's affecting a lot of people. So that brings us to our current slide, the global population. And as we think about the history of pandemics, it's helpful to get a handle on numbers, especially related to population. So this chart shows the global population from the year 1 AD to 2050. So that red line shows that's what the projected population is going to be. And today the world population is around 7.8 billion. And some demographers project that our global population will rise to 10 billion by 2050. But this rapid population growth, you know, where the line is going up very quickly, relatively recent. We only had about 3 billion people on the planet in 1960. That's when my brother was born. And today we're at 7.8 billion. So within his lifetime, the world population has more than doubled. But think about what that means in terms of infectious disease. So our world now is more urban. For the first time in human history, there's more people living in cities than in rural areas. And again, think about what that means in terms of the spread of infectious disease. You've got people living closer together in densely populated areas. The growing population also means there's increased need for food, clean water, sanitation, healthcare, and the lack of any of these, which are considered human rights in most countries, makes people more susceptible to infectious disease. The growing population also impacts climate change. So as more people consume more fossil fuels, which contribute to climate change, that can impact the range and prevalence of infectious diseases. For example, here in Wisconsin, we're seeing more Lyme disease, and that's due to milder winters, which has lengthened the tick season. And human populations are also spreading into areas where they haven't previously lived, and they're encroaching on animal habitats. That's putting us at an increased risk of zoonotic diseases, something, again, that's spread from animals to humans, like COVID-19. And then climate change impacts our food supply. We've got extreme weather events, hurricanes, droughts, floods, which destroy crops. And as we mentioned, we need access to a healthy diet to strengthen our immune systems to help ward off disease. So there's many intersecting factors that we need to attend to. So the 10 worst pandemics that we're going to go through very quickly today are shown on this slide. And we're going to go to starting when the global population was around 220 million people. Obviously, there aren't precise records for many of the earlier pandemics, and these are worst in terms of the number of people who were killed. But it's worth looking back in history because theoretically, we can learn from past pandemics and how to better prepare ourselves and respond to current and future pandemics. So the first pandemic we'll talk about is the Antonine Plague. And this occurred between 165 and 180 AD. It's sometimes referred to as the plague of Galen. Some of you have probably heard of Galen. He was a physician. And he was a physician that documented this plague, which is sometimes why his name is associated with it. Well, it's called the Antonine Plague. It most likely wasn't the actual plague. Some researchers think it may have been caused by smallpox or measles, but the true cause is still unknown. And this was during the time of the Roman Empire, and the plague seems to have spread from the Middle East back to Europe by troops returning from battles. But it was very deadly and decimated the population of Rome. Some historians cite it as the single greatest cause of the weakening of the Roman Empire in Northern and Eastern Europe. And it also killed the Roman emperor, Marcus Aurelius Antoninus, which is where the name of the plague, the Antonine Plague, came from. So as we mentioned, historians think it may have been caused, that this wasn't a true plague, but it might have been caused by measles or smallpox due to the symptoms that Galen had recorded. So things like fever, eruptions, diarrhea, rash on the skin, and it killed up to the population in some areas and is estimated to have killed 5 million people. There was a brief resurgence of it in 189, which killed up to 2,000 people per day in Rome, and it was killing 1/4 of the people who were infected. So here's a photo, an engraving that was done by a French artist, Levasseur, depicting the Antonine Plague. And you can see the title of the photo here, The Angel of Death Striking a Door. During, in this case, it was called the Plague of Rome. So the next plague we're going to talk about is the Justinian Plague. And this great pandemic occurred between 541 and 549 AD. And this one was a true plague, a bubonic plague, which was caused by the Yersinia pestis bacteria. And it affected people throughout the entire Mediterranean basin in Europe and the Near East. It's called the Justinian plague because after the Roman emperor at the time, Justinian I, he had contracted the disease, and later recovered. And as you might recall, the plague is spread by the fleas of small animals. So the Justinian plague spread via rats, and it seems to have started in Egypt and then was carried to Constantinople, which is current-day Istanbul in Turkey, by infected rats on grain ships. So this was a very deadly plague, which killed about half of the population of Europe and 1/4 of the population of the Eastern Mediterranean. It's estimated to have killed 5,000 people per day in Constantinople during the height of the pandemic and killed 4% of the city's population. And overall, it's thought to have killed about 25 million people. And you can see a picture in the bottom right of the slide depicting the plague going on at the time as it was imagined later by artists. So the Justinian plague was a bubonic plague, and symptoms included fever, headache, chills, and swollen and painful nodes called buboes, which is where the name bubonic comes from. And on the right, you can see a photo of the buboes, these swollen lymph nodes in the photo. And the plague still exists today, including here in the southwestern United States. But today we've got ways to prevent it, and we've got antibiotics as well to treat it. But it can still be quite deadly. It's got a 10% mortality rate if it is treated, and a 30 to 90% mortality rate if it's left untreated. So the next pandemic we're going to discuss is one that probably everyone has heard of, the Black Death. And this also was a bubonic plague, and the peak years were around 1347 to 1351. And it was the deadliest pandemic in recorded human history. It's thought to have originated in Central or East Asia and then traveled west along the Silk Road to Crimea. And then from there, it was carried by fleas living on rats that traveled on Genoese merchant ships to Africa, Western Asia, and throughout Europe. And then once on shore, it was spread by human fleas. So once it started spreading by human fleas, it spread very quickly because the human fleas can carry a version of the plague, the pneumonic version of the plague, which is spread much more easily between people. So as we mentioned, the Black Death was the deadliest pandemic in recorded human history. It killed anywhere from 75 to 200 million people worldwide, including 30 to 60% of Europe's population. And it reduced the world population from 475 million to around 350 million. And it took 200 years for Europe to regain its population to be at an equivalent level as when the plague had started. And again, you can see more artwork here in the bottom right depicting the plague. So the plague there's different types or different versions of it. We mentioned the bubonic plague earlier, which comes from the bite of an infected flea. And then we mentioned the pneumonic version of the plague, which is why the Black Death spread so quickly, because the pneumonic version can be spread via infectious droplets, like when people are coughing or sneezing. It's also the most serious form of the disease, which is why it was so deadly. But there's also a septicemic version of the plague, which can evolve from the untreated bubonic version of the plague. And septicemic plague can cause skin tissue to turn black. And you can see the photo in the upper right, how the skin tissue has turned black. And that's where the name of this disease, the Black Death, came from. And as you mentioned, the plague still exists around the world. You can see the map here in the bottom center of the screen. It exists on all continents, except for Australia and Antarctica, but it's still with us today. So moving on from plagues and jumping several centuries, the third cholera pandemic occurred much more recently. So the peak time for this was around 1840 to 1860. And this was a third major outbreak of the disease in the 19th century. This particular pandemic originated in India and then spread throughout northern India, other parts of South Asia, throughout East Asia, as well as Europe, North America, and Africa. And we don't encounter cholera very much here in the US, but it's something that gets spread through contaminated drinking water or food. In this particular pandemic, the third cholera pandemic, was considered to have had the highest fatalities of 19th century epidemics. The third cholera is estimated to have killed over 1 million people. And in Great Britain in 1854, it killed about 23,000 people, including 10,000 people in London alone. And I'm sure some of you recognize the picture of the gentleman in the top right of the screen, and you've heard of John Snow. He's considered the father of modern epidemiology. So he was around at the time that this third cholera pandemic was going on, and doing research in London. The people getting their drinking water from a certain pump in London were more likely to get sick. So the image on the bottom of this map shows how John Snow documented where water pumps and cholera cases were happening in poor areas of London. And so after putting together this map, this is credited with being one of the first epidemiological studies, he noticed that there were a lot of cholera cases around the Broad Street public water pump, people who were getting their water from that pump. And he had a very high-tech solution for helping to stop the spread of the disease. He removed the handle from the water pump. So again, because many of us here in the US might not be familiar with cholera, I'll just briefly go over the symptoms. It includes things like vomiting, diarrhea, circulatory collapse, and shock. And if it's not treated, 25 to 50% of severe cases can be fatal. And for those of you who travel internationally, you're aware that cholera is common in many parts of the world. And you can see the map at the bottom shows countries that reported cholera cases within the last decade, between 2010 and 2015. But do you remember earlier on, we were talking about the growing global population and the need for clean drinking water and sanitation for everyone? So cholera is a really good example of an infectious disease that can become pandemic in proportion if people don't have access to clean drinking water and sanitation, which is one of the main ways we can help prevent the spread of cholera. So we skipped, hang on, sorry about this. So our next pandemic is another flu pandemic. We're going to be talking about a couple of them this morning. And this is a flu pandemic from 1889 to 1890. And this has also been called the Asian or the Russian flu because the first cases were reported in the Central Asian city of Bukhara, which was then part of the Russian Empire. So the flu, this particular flu strain in this pandemic was spread via railroads and transatlantic boat travel through Europe, Asia, and the rest of the world. So as the world is more interconnected, and again, we'll be talking about some lessons learned in the future, but when you think about air travel today, as people can travel more easily, it's much easier for it to spread. So most likely this particular flu pandemic was called the influenza A virus. Although some recent genomic virological studies think it might have been a human coronavirus, but it killed about 1 million people, a fatality rate of around 3.3 to 4% at its peak. And this was the last great pandemic of the 19th century. Due to this particular flu pandemic in 1889 to 1890, influenza became a notifiable illness. So that means if the disease springs up, it must be reported to government authorities. So in between a couple of flu pandemics, there was another deadly cholera pandemic in 1889 to 1923. So Russia and the Ottoman Empire were hit especially hard. More than 500,000 people, so 500,000 people, died in Russia during this pandemic. 200,000 people died in the Philippines, and more than 800,000 died in India. And it spread to Europe, it spread to the Middle East and North Africa as well. So the last cholera outbreak in the United States was during this pandemic between 1910 and 1911 here in the US, and 11 people died here. But having learned from previous pandemics, American health authorities quickly tried to isolate infected people and tried to stop the spread of this disease. In 1910, some infected individuals were traveling from Naples, and they arrived via steamship in New York City, and health officials quickly quarantined these infected people. And that's why our death toll in the US was so low during this particular outbreak, with only 11 people dying. But stigma was also very prevalent during this outbreak because immigrants and travelers tended to be, they were the ones who were carrying this disease from infected locales and other places. So it came to be associated with outsiders. And in the US, for instance, people from the Philippines were blamed for bringing cholera, even though the 1910 outbreak in the US arrived from travelers coming from Naples. And in Great Britain, people from India were often blamed as carriers of cholera. But again, when we think back, stigma is related to diseases, especially infectious diseases, and how that can stymie control efforts. And so what can we learn from the past? Next up, we've got the flu pandemic of 1918. And this is something many people have heard of and often look at for comparisons with the current COVID-19 pandemic, even though COVID-19 is not the flu. But the flu pandemic of 1918 is sometimes referred to as the Spanish flu. And this is because had to do with what could be reported in the news at the time, especially during the flu outbreak. A lot of information was censored in many countries because European countries wanted to keep up morale during World War I. But the press in Spain was not censored. And so the flu was reported on there. And in fact, the King of Spain had become very ill and from this particular flu, got covered in the papers. So it created a false impression that Spain was really hard hit by the flu. And that's why sometimes this gets referred to as the Spanish flu. But it was easily spread because World War I was going on. And so you had troops living in close quarters and then serving in the war, and they spread the flu throughout Europe, the US, and it was spread around the world. But the other really notable and unusual aspect of this outbreak was that it hit young adults very hard. Mortality rates among young adults were much higher than expected, or that we would usually see with a normal flu. Between February 19 and April 1920, about a third of the world's population was infected with this particular flu. And the death toll was estimated anywhere from 17 million people, a very wide range. And some scholars claim the death toll could have been as high as 100 million. And this was definitely one of the deadliest pandemics in human history. So we've got a couple of more flu pandemics that we'll discuss very briefly. The next is the Asian flu, spread during 1957 and 1958. And this originated in China, which is where the name the Asian flu came from, and then spread throughout the world. And this particular pandemic as well was estimated to have killed over 1 million people, including around 100,000 people in the United States. They noted infections spread very easily among children in school, which led to school closures, which sounds familiar to many of us today. And this flu outbreak was especially deadly among pregnant women, as well as among the elderly and those with pre-existing heart and lung diseases. So the pandemic also had a devastating impact on the global economy. In fact, the Dow Jones Industrial Average lost about 15% value in the second half of 1957. And again, many similarities were seen with today about, the economic impact of these pandemics while we're living through them. So cases of the flu first reported in Hong Kong in 1968 spread around the world to become the flu pandemic of 1968, sometimes called the Hong Kong flu. And again, this is another one that many people living today have heard of or remember. Cases were first reported in Hong Kong, and then from there it spread to Vietnam and other parts of Asia, to Australia and Europe, and it was carried to the US by troops returning from the Vietnam War. It's estimated to have killed between anywhere from 1 to 4 million people worldwide, including about 500,000 or about 500,000 people in Hong Kong, which was about 15% of its population at the time. And you can see the highway sign in the lower right here. It says Hong Kong flu is un-American, catch something made in the USA. But I point this out because we can see that, stigma has continued to be an ongoing problem throughout history with people burdened by infectious diseases. So some scholars posit that HIV/AIDS is a pandemic, although the World Health Organization refers to the global epidemic of HIV. In 2018, nearly 38 million people worldwide were infected with HIV. And it's estimated that 36 million people have died from AIDS since 1981. So this is also a zoonotic disease. It's something that came from primates, came from chimpanzees in sub-Saharan Africa. And sub-Saharan Africa shoulders an especially high burden of HIV. More than 70% of people infected with HIV live in sub-Saharan Africa, even though only 13.5% of the global population lives in sub-Saharan Africa. So you can see the tremendous burden this places on that region of the world. And I mentioned earlier about working with a research team in Malawi and Kenya. And these countries are very, very hard by the HIV pandemic. And you can imagine the burden on the healthcare systems there, especially with Malawi being one of the poorest countries in the world. So I've got a map on this slide here. Malawi is located in southeastern Africa. It's actually on Lake Malawi. Africa has a series of Great Lakes as well. And the photo in the bottom right is some kids in Malawi. But HIV has hit the adult population really hard. So people who are in their prime working years, which makes sense because that's the same age group that tends to be sexually active, which helps to spread the disease. But it's also resulted in a high number of orphans in these countries. So my colleagues and I recently completed a qualitative study with women receiving end-of-life care in rural Malawi, many of whom were infected with HIV and which had progressed to AIDS, which is why they were in end-of-life care. And we have a paper coming out this month on some of our key findings. But one of the main findings was about food insecurity among these women and their caretakers. And we mentioned the connections between food and infectious diseases early on. So in very poor countries like Malawi, if women are food insecure and don't have enough food to feed their children or families, they may turn to transactional sex to get money for or to barter for food, which puts them at risk for contracting HIV. And Malawi is also about 80% rural, with many people are subsistence farmers. So that means they're growing their own food to feed their families. Many of these are women. But when women are sick with HIV, they might be too weak to be working in their home gardens and then children have to quit school to try to farm or take care of sick parents. And it just perpetuates this vicious cycle of poverty, which is fueled by infectious diseases. And malaria has the same impact throughout much of sub-Saharan Africa, which hits kids and adults alike. But when adults get struck with a bout of malaria, they're missing work, they're losing those wages. When kids get struck with a bout of malaria, they're missing school. And when they start missing enough schools, they fall so far behind. And then again, you can see the vicious cycle. Can't get good jobs and as adults. So there's a real need to address not just infectious diseases, but some of these structural issues that underlie them, like global poverty, access to food, access to clean water. So that was a really quick walk through the 10 worst pandemics that have killed the most people globally. And have we learned anything from the past? Well, as the slide says, a lot of this isn't rocket science. We know what works. We know that quarantines work, keeping people isolated so affecting other people. And relatedly, we know that social, or better yet, referring to it as physical distancing, helps. Keeping people spread apart so they're not as easily transmitting diseases. Wearing a mask helps. It helps decrease the spread of airborne diseases like the flu or COVID-19. And we know that good hygiene helps. So washing our hands, regularly cleaning that people touch. Like we're seeing now, fresh air can help lessen the concentration of infected particles in indoor air. So this fresh air lessons learned, something that went back to the flu pandemic of 1918 and they related it to adaptive schooling. So at the time, encouraging schools to open their windows, open their doors, have classes outside if possible, again, to have access to fresh air to help reduce, so the virus wasn't spreading so easy in concentrated indoor areas. But again, we're seeing the same thing now with adaptive schooling and things online. The next thing I have on here is about changing cultural practices, which we all know is really hard to do. So as we've talked about COVID-19, it's a zoonotic disease that most likely came from a bat in what's called a wet market in China. And I'm sharing this photo on the slide. This is from rural China. I use air quotes because this particular city, Zhejiang, is a city of 1 million people, but it's considered rural. It's rural enough it doesn't have its own airport. But in terms of China, 1 million is a relatively small Chinese city. And this is a photo of just one regular stall at the regular daily market in town. And you can see the live animals for sale. You can see there's small mammals in cages on the right. There's turtles, other things from the sea. This town happens to be right on the Yangtze River. But this is every day. This isn't even the wet market. The wet market actually has a lot more blood and guts, might be the way to put it. Just to give you an idea of how easy it is to imagine how diseases might spread between animals and people. When you're used to eating this way, you're used to shopping this way, you're used to getting your, fresh food this way. And it's hard to change how we live and the ways we've always shopped and eaten. Another thing, as I mentioned, about the structural issues that underlie many of these pandemics now and throughout history is if we had a more equitable distribution of resources that could help to lessen the impacts of pandemics. So we're seeing that here in the US during the COVID-19 pandemic. Our Latino and African American communities, which tend to be poorer with less access to healthcare, they're the ones that are disproportionately impacted. But as we all know, we as human beings, we can be very stubborn. We seem to have very short memories. So we have data, we know what's worked in the past, and it's really hard to understand why we won't implement what we know has worked. So while we're going through the current pandemic, I know the days seem long, but as we once this passes and years down the road, as we look back, the year or years will have seemed short. So we'll talk a little bit more about this, some lessons learned, but looking into the future, as people look back to this current pandemic, I think they're going to be wondering why didn't we do more to prevent the spread? We know what worked. The world has been through other pandemics in the past. Why weren't we implementing and doing more things to prevent more people from getting infected and more people from dying? So as we look back, especially looking to the flu pandemic of 1918, things weren't much different than compared to what we're seeing now in the US during COVID-19. Both COVID-19 and the 1918 flu were novel diseases. So that meant these were new diseases. One of the reasons they were so devastating is people had no immunities to them. So there were a lot of available hosts to infect. Some other similarities is there was no vaccine then for the flu, just as we don't have a vaccine yet for COVID-19, although hopefully one will be coming in the next several months or next year. Both of these were airborne diseases. So they're diseases that are spread through the air. They're respiratory droplets that are released when an infected person coughs or sneezes or talks, and then they can be inhaled by anyone nearby. And as we know, we keep getting coached to do this to make sure, be careful what we're touching, make sure we're washing our hands, because when an infected person maybe touches something and then we touch it, we might pick up that virus as well and get it into our system. Some other similarities between the flu of 1918 and today's current pandemic has to do with lies and censorship and propaganda, which helped fuel the spread of the 1918 flu. So I mentioned that information was censored about the flu to keep up morale during the war. And there was a lot of political pressure on what information was being released. Does that sound familiar to today? And today we also see misinformation spreading on social media, which can have a much quicker impact. In 1918, there were issues with ignoring the science. So scientists and healthcare professionals were advocating for containment measures to stop the spread of the flu, but that advice was ignored partly due to the war effort. So again, do we see any similarities today with ignoring the science? There were issues in 1918 during the flu pandemic with large public gatherings. During World War I, cities hosted something called Liberty Loan Parades, and it was to raise support for war bonds. During the 1918 flu pandemic, some big cities ignored health officials' advice and had parades, which were attended by thousands of people. So Philadelphia, for example, had a parade in 1918, which an estimated 200,000 people attended. And 2 days later, every hospital bed in the city was filled. Does that sound familiar to today in hosting large political gatherings or rallies or other public events? There was also an issue with misplaced priorities. So the priority in 1918 was on winning the war. And do we see any parallels today with the upcoming elections? And as the headline shows here, in 1918, there was resistance to wearing masks, as we're seeing today in the US as well. But we know, again, looking back at the data, that cities that had strict mask wearing orders during the 1918 flu pandemic were far less impacted. They had fewer people getting infected and they had fewer deaths. So I mentioned the United Nations Sustainable Development Goals, or the SDGs, at the very beginning, and I want to mention them again now, because many of us here in the US haven't heard of these. So these are global coordinated goals for all countries to strive to meet by 2030. And each goal has specific and measurable targets and indicators, so we can actually measure how well our country or other countries are doing in making progress toward meeting each goal. And I want to bring these up because they're very relevant to the current pandemic and our situation here in the United States. So for example, one of the targets in SDG number 3, which is good health and well-being, calls for achieving universal health coverage and access to safe, effective, quality, and affordable essential medicines and vaccines for all. So think about if we already had this in place in the US, how it could help those suffering from COVID-19. And I would also mention that the US is the only high-income country in the world without some sort of universal or national healthcare plan. We also pay the most for healthcare here. So other countries have better health outcomes for their populations at far less cost. So is there something we could be learning from other places that would also help us to better address the COVID-19 pandemic? Another target within SDG number 3 has to do with ending AIDS, TB, waterborne diseases like cholera, and other communicable or infectious diseases, which is very relevant, again, to our discussion of pandemics. Others of these goals have to do with partnerships for global health. So how can we work together to improve health outcomes among populations in each country, but also cooperating to help stymie the spread of pandemics. The SDGs also relate to making sure we all have access to clean water. So again, coming back to the cholera pandemics, access to clean water would help to suppress that. Addressing climate change, which we talked about early on in relation to population growth. So again, there's all things that each of us can do to help better respond to future pandemics. And I would encourage you to take a look at these SDGs, especially if you've never heard of them. There's a link on the bottom of the slide, but you can also just Google the UN Sustainable Development Goals. So finally, I want to make sure you're aware of resources if you're interested in learning more about global health. First of all, there's the UWM, University of Wisconsin-Milwaukee Center for Global Health Equity, which is housed in the College of Nursing. So through the Center for Global Health Equity, we have global health courses. We actually have a new course that's going this fall on global infectious diseases. I'm trying to remember the exact title, but it's very pertinent to what's going on today. But we have global health courses. If you're interested in just taking a course or auditing a course to check it out and see if you're interested, you are more than welcome to. We offer a global health certificate, and that too is open to anyone. You can come and just do the certificate if you like. We have a baccalaureate degree in global health, which is new and the first of its kind in Wisconsin, and it's part of our global studies program. We also offer short-term global health study abroad programs. We have programs that go to Malawi and Kenya, countries I mentioned earlier, and also a program that goes to Thailand, to Ecuador, and one to the Dominican Republic. So again, these are open to all. They're open to healthcare practitioners, but also people who just have an interest in learning more about global health. Anyone is welcome to join us on these programs. And all of our global health programs at UWM are founded in this UN Sustainable Development Goals framework. So they're looking not just at the clinical applications, but again, these broader structural issues that impact global health. The next resource on this slide is the Milwaukee Global Health Consortium. So this is a group of Milwaukee area colleges and universities that are working together on various global health initiatives. A popular one that we have going is the Global Health Scholars Program, and this is open to students from any Milwaukee area college and university who want to meet other students interested in global health. It's free, and students can earn a certificate if they participate. We also recently completed a global health impact study, which documented the economic benefits of global health here in southeastern Wisconsin. The next resource on the slide is a consortium of universities for global health. So this was founded by the Bill and Melinda Gates Foundation, who, as many of you probably know, fund a lot of global health initiatives. But this is an organization anyone can join as an individual, and it's relatively inexpensive. I think it's like $75 a year. But they've got a lot of resources. And they also do a really good job of providing resources and opportunities if you're interested in getting involved in advocacy with elected officials. You know, how can you help influence people and to participate in global health initiatives and address things like the COVID-19 pandemic. The next resource on the slide is a Global Health Now newsletter. So this is a weekly newsletter that's put out by Johns Hopkins University, and it's free, and it offers comprehensive weekly updates about what's going on in the world related to global health. So it just comes into your email every week, and they're a really good resource if you're interested in staying very up to date about what's going on. I also have the World Health Organization on here. They are an excellent resource for data and information about global health. And I mentioned advocacy efforts when I talked about the Consortium of Universities for Global Health. This is something I did on behalf of CUGH, Consortium of Universities for Global Health, just 2 weeks ago. We contacted our Wisconsin elected officials, and one of the things we were advocating for was asking our elected officials to urge the US administration to re-engage with the World Health Organization and pay our dues. So while the organization, it might need some reforming, most people would not disagree on that, but our feeling is that we can better influence that reform process if we're actually at the table. And finally, please feel free to drop me an email if you have more questions beyond this question and answer period. I really want to thank you for your time, and I hope you learned a little bit about the history of pandemics. We've got time for a few questions, and if opportunity exists, I've got a few questions for you I would like to pose. So thank you very much.
Thank you very much, Anne. If anybody has some questions, they can type them in the chat window.
And while people are maybe thinking of questions, some questions I would pose out to people on the webinar to think about or to offer their thoughts in the chat is, what are your thoughts about how we can better learn from past pandemics to address current and future pandemics? That's one question, if you have thoughts about that. Another is, what are your thoughts about the example we're setting for our children or grandchildren regarding how the U.S. is managing the current COVID-19 pandemic? And the last question I have, if anyone wants to weigh in, is, does anyone want to share their experience they've had in another country in which they've lived, worked, or studied, and what the healthcare system is like there, or how that country might respond to a health crisis?
Annie, we do have a question.
Okay.
Darcy asks, we have a mask mandate and the curve is not flattening. Is this because it's not being enforced, or is there a possibility masks are not working?
Masks definitely work. We do know that. But as we've seen and heard, many places a mask mandate is not only not being enforced, but in many places, people are just blatantly ignoring it. And I know we've all heard discussion about, it should be my right whether or not I wear a mask. People shouldn't be telling me what to do. But when our behavior is harming others, I think we all have to take personal responsibility. So wearing a mask helps us protect other people. It keeps us from harming other people. If it were just a matter of the mask protects me, well, then yeah, then it's up to each of us if we want to wear it or not. But the mask keeps us from harming others, which is why it's so important. And the masks do work.
Okay, we have another question from Kit, and I apologize. I don't want to botch your last name. Most of the pandemics have lasted about 4 to 5 years. Do you think COVID will last that long?
I hope not. I actually don't think so. There's been a lot of money. There's been actually global coordinated efforts on coming up with a vaccine. And that's one difference between this current pandemic and 1918 is there's so many more systems in place right now for scientists to collaborate and cooperate with each other on things like coming up with a vaccine. So I think that process will move quicker than it has many times in the past. We have, as you all know, very good infrastructure now for helping to get the vaccine distributed. So I don't think it'll last that. I think it's going to be a long winter. I think 2021 is going to be hard, but I don't think it's going to be 4 to 5 years. On the other hand, this is brand new. We don't really know, but I really think it's not going to be that long.
Okay, I think we have time for another question. Katie Hughes asks, when a vaccine does become available, how confident can we be that it will be safe and not have long-term effects?
That's a really good question, and something, as we all know, people are very concerned about right now. Many of the federal organizations now are coming out with very stringent guidelines. They're being very transparent about everything that the vaccine development, as you've heard, some have been put on hold because there's been a person here or there who's had an adverse side effect. So they're being very transparent about this whole process because they want people to have confidence in it. And there's been guidelines developed to make sure that, every protocol is being followed to ensure that this vaccine is going to be safe and effective. I know people are concerned and everything we hear in the media that's going on with it, but I'm quite confident, I should say I'm very confident that the vaccine will have been vetted very thoroughly to ensure that it is safe for us to take.
Okay, we have a question from Amber Ford. Can herd immunity be achieved without a vaccine? How did the previous coronavirus pandemic end in 1890?
So some of the previous pandemics, yes, that's part of what happened. They moved through the population, and so enough people had been sick from it so that they became immune. A vaccine was eventually developed. But for different diseases and different pandemics, there's different levels of herd immunity that you need. And they're still trying to figure out what that might be for COVID. The argument against just letting this run through the population, so that enough people get it, that enough people are immune, is that it will cause a lot of unnecessary illness and death. So we're close to having a vaccine. And if we were all, I know we know it's not even hard, but it's kind of annoying, right? To have to wear a mask, practice social distancing and stuff like that. But it's not that hard to do. And if we were to do that consistently, all of us, until we get a vaccine, we could avoid a lot of unnecessary illness and death. So at some point, a few years down the road, between the vaccine and enough people having contracted this, it'll pass. But I think that most health officials would agree that's not the thing to strive for right now, because a lot of people will die unnecessarily. A lot of people get very sick unnecessarily if we just say, oh, that's going to be our strategy.
Well, Anne, thank you very much. I appreciate it. Fascinating information.
Thank you very much. Thank you for having me.
Okay, so we are going to take a 5-minute break, a leg stretching break. And welcome back. I would like to welcome Eric Connolly, Executive Vice President of Froedtert Health and President of Froedtert Hospital.
Good morning.
Good morning.
I've been listening a little bit to Dr. Dressel earlier. It's interesting questions and fascinating information. And it's sort of, as much as we've been through some things in the past, this is still unprecedented. And some of the questions were great. And I wish we had all the answers. And like her, I absolutely hope we do not go 4 to 5 years in this aspect. But it's uncharted. So we'll see how it goes.
Thank you very much.
So I guess we'll go ahead and get started, Chris. What I can do is I can actually share my screen, and then we'll begin. Is that okay?
That's perfect. The podium is yours.
All right, great. Hold on here. First, I want to start by finding the presentation and give you a little background to everyone on myself here. So there, hopefully everyone can see my screen. Let me start just by saying it's an absolute honor to be with you all here today. I'm especially excited about it because my first job in an academic medical center, my first job in a hospital was as a HUC at the Ohio State University Hospitals is what it was called at the time. Now it's the Ohio State University Wexner Medical Center. I served as a HUC there back in the days when you had to actually, when you're filling out the blood orders, you filled out the different cards. What used to be, I guess, Chem 7 and Heme, CBCs with DIPS, all on the Hemes were on the blue cards, the chemistries were on the red cards. That's how long ago that was. And I worked as a float. And as a float, I was in every single department, every single unit in the hospital during the time I was there, about 2.5 years. I was there while I was in graduate school. The experience was amazing. Worked all shifts, day shift. Predominantly, I worked in the evening shift from about 3 o'clock in the afternoon until about 11 o'clock at night, and then sometimes worked the night shifts. And in that evening shift, you really got to see a little bit of everything. Really busy time, particularly between that 3 o'clock time frame and say 8 o'clock at night, where you had discharges going out, you had people coming in, the ORs were emptying out. Really got to understand how a hospital works from a patient flow perspective. You also get an opportunity to see just how hard our care providers were delivering care and how difficult it was, how great they were, understanding the true partnership between the physicians and the nurses and how well they work together. So it was an extremely rewarding and rich experience, one that I've called upon throughout my career and even to this day and really helped me in the job that I have. So as mentioned before, I am the Executive Vice President of Froedtert Health, an academic health system here in Milwaukee, Wisconsin, and President of Froedtert Hospital, which is our academic medical center. Right now, we're about 750 beds. We operate about 710, and we'll expand to 800 when we open up another campus in June of 2022, I think is our targeted timeframe. And today, very much like earlier, we talked about the history of the pandemic. What I want to give you an insight into is a little bit about how Froedtert Health managed the pandemic. And we'll walk you through different information, different processes, different thought process of how we managed through our incident command, through our recovery command, and then transition into day-to-day normal operations, if we can call really kind of living in the COVID world normal. And then how we would potentially move back into it if a surge continues to go. At any point in time, Chris, if you can manage this, if there are some questions, just please put it in the chat. We have about roughly just under an hour. We're happy to stop and answer any questions as we go on any topic, whether it's the pandemic, how we handled it, sort of the day-to-day, or just any thoughts about how hospital leadership, hospital operations, their thought process goes into when we're in that incident command or just day-to-day operation. Okay, so with that, we'll just start with when this first started out, and I want to give a shout out to all the individuals who came to support all of our care providers. As you see here, this was during the height in the March, April timeframe. just so many wonderful outpouring of warmth, gratitude to all of our care providers here on campus and throughout our community hospitals and everything. And it was really, really touching. So touching that when we had our United Way campaign, many of our employees gave back through the United Way, understanding that all those individuals out there that provided meals, that put masks together for us, really were also in need of help themselves. And the United Way was one of the best ways we could give back to the community that gave us so many things. And this is just a couple of pictures and examples of the outpouring of care and thanks that we saw from the community. So COVID-19 and flattening the curve, as this is sort of some of the data points that we would start every day before we went into our incident command and make decisions on how we would move forward. And we look to our experts, both here and in the state, to provide this data point. And so before we actually activated our enterprise command, I'll walk you through that and sort of our thought process. But here's some of the information. Now, this data is a little dated. It wasn't what was showing at the time, but this gives you an example here of what we were looking at, the leaders here at Froedtert Health, when we decided that, hey, we need to call into the command and really drive forward. This is some of the data points. We would look at this, see what the surge would happen if things were in place, what we knew at the time based on things that were happening in New York and other major cities in Chicago. And this is what we assessed. We looked at trends, how things would happen, and took the worst case scenario to hand. And we began to start planning for that. And that planning went from everything from staffing, allocation of beds, supplies. As you recall, back in March and April, PPE was a very, very scarce resource at the time. But this was the beginning of our thought process. And you see, as time went, this goes back even into March, sort of how things were all over the place there with different peaks at different times and different projections. But this is sort of the data that we would look at on a daily basis. Then we really, once we started and launched our incident command, we decided that let's put a surge plan in together. That surge plan was, and we'll have a couple of later slides that walk you through that. It was formally launched, our EIC, on March 26th. But prior to March 26th, we had routine meetings with a small group of executives that we called our Unified Command, where we talked about the data that I showed before, sort of how we would put together a team, how we would run incident command, and our thought processes behind that, how many operational periods we would do. That was in place 2 weeks prior to this March 26th date. And on March 26th, we formally launched incident command. So when we launched it, we did say, let's do our surge plan and design what that looks like. So we put together a team, and that team went off and for 2 full days worked out enterprise-wide. And enterprise-wide consists of Froedtert Hospital, Froedtert Menominee Falls Hospital, which is a 200-bed community hospital, and Froedtert West Bend Hospital, which is a 72-bed hospital in West Bend. Took into account every bed, every space, staffing, supplies, all vetted out within 2 full days of a team of team members in our incident command structure. And they came back with the plan for how we could expand. And at the time, we were able to expand to up to 400 additional beds. Another additional 150 ICU type beds is what we're able to surge up to. Again, when we're talking about March and April, we really didn't know how bad it would be. We were looking at some of the data coming out of New York City, New York Presbyterian, and all the other hospitals there. And we're really saying, hey, this is going to get bad. We need as many beds as we possibly could. So we found out, through that expansion and opened it up in phases. Hey, here's what it'll be for phase 1. Here's phase 2. Here's phase 3. And phase 3 represented between 300 and 400 new beds. And then the staffing that we would need to go through it. As we looked at, expanding, we knew we would actually reduce services. So that's where some of the staffing aspects would come into play. As different services are reduced, the staff would then be transitioned into working in our inpatient sites, both in the what we call our acute care beds, and then our intensive care beds. And as you can see here, here are the different stages of surge and different phases, both of critical care as well as acute care. All this was laid out and presented to our unified commanders, which consisted of myself, our enterprise CMO, our practice CMO and president and CEO of the practice plan, experts in safety and quality and nursing operations. Here's another slide. What was imperative and what worked very well is Milwaukee County, their public health collaborative, put together this unified command. So all the information that we had out of our incident command at Froedtert Health, some of that information was fed into this structure here, which is then coordinated throughout all of what we'll say Southeast Wisconsin is what this is able to get to. So information began to be shared both on PPE, bed, even some staffing of all the healthcare facilities in Southeast Wisconsin. So the information from each entity began to pour into this organizational structure so people knew what each of the different entities was experiencing and how we could collaborate. Great opportunity there to really collaborate on such an emergency. And then this was an emergency, unlike obviously a hurricane or anything else that may come through. This was one of those long-term effects that we were planning for. So this information, this structure here worked extremely well. I think I skipped one. So what I want to share with you here is what our enterprise incident command structure looked like and some of the people in it. Very high level, it was very traditional. It was laid out back in the 9/11 days. We put it together with the modification of our president and CEO, Kathy Jacobson. We would brief her after we would have our unified command put together. So you see our safety officers, liaison officers, public information, our medical technical specialties. All those individuals were in place, lining up, providing that unified command information about how to proceed. Down in our operational areas, we had logistics, finance, planning, and operations. In each of those boxes, we put individuals in those boxes, and they did a phenomenal job of being organized. It was the folks in the planning section there that created that surge plan that you saw earlier. It was just an amazing coordinated effort. The structure of such a thing, what was put in place to make sure things go and get communicated very smoothly, safely, and unified. And that's exactly what happened in this incident command process. So what I just want to do now, Chris, if it's okay, is just ask if there are any questions of what you've heard so far or any thoughts that anyone may have, if anyone had an opportunity to participate in their organization in something like this during the last 6 or 7 months. So I'll just take a little pause here to see if there are any questions that may come up so far.
Doesn't look like you have any questions yet.
Okay, again, please feel free, put them in the chat. Chris, just interrupt me if there are questions that do pop up. I'll be happy to pause the presentation and get right into it and answer those questions and get back to it. All right, so with that, we then the incident command from March 26th all the way through to the end of April. And if you recall, many in the Wisconsin area, we started to see a definite plateau and a reduction in the number of hospitalizations that was occurring, particularly in the Milwaukee County area and at Froedtert Health. So at that time, that last week in April, we had discussions about how we would then manage going forward. We made the decision, let's go out of incident command and let's go into recovery command. Because at the time, if you recall, we shut down all elective procedures due to our access to PPE. And how do we then now begin to come back up, knowing that there could be a spike at any time? Weather was getting warmer. We didn't know at the time, all right, if people started getting together because the weather was warm, would that be a factor? Different max mandates were beginning to be put in place. Restaurants and everything were closing. But in May, there was a lot of talk about how things would start to come back up. And so we decided at that time to go out of what was incident command and then move into what we called our recovery command. So slightly different. And what we did is look at what all our operational objectives were, the final operational objectives, in our incident command, and then transition that into what we call our recovery command, that approach.
We have a question.
Sure.
I have a question. Your presentation indicated a Surge 1 and Surge 2. Are we currently in Surge 3?
In the presentation, Surge 1 and Surge 2. No, I would say we're in Surge 2. What we're referring to as 1 and 2 is the incident command and then recovery command. That may be, sorry for that confusion on that, but that's what we're in right now with the different spike in cases. Right now, what we're in is a little bit more of that Surge 2 is what I would call it. Good question. So going back to our incident command back in that April timeframe, we were making sure that some of the things that you see on the screen there to the right, that we're able to triage and treat COVID-19 patients. We started to get that down quite consistent and very comfortable with that. We controlled access to our facility, but we were able to preserve PPE. We actually had indicators and predictions on how much PPE we would use. That got down to a point where we know for each surgical case how much PPE we would know almost to every patient how much PPE would be used by patient. So we were very comfortable. We started to get our supplies in, but we knew how much we would use, so we were then be able to go strategically and begin to open up. As you see, we leveraged system-wide framework that we discovered in the incident command and transitioned that into our recovery command. So as you see there on the screen, we had a very similar approach. There were some fewer forms that we required, but the structure and the infrastructure and the decision, which we were rapidly doing in a week time frame, in incident command, to that same weekly objectives going forward in the recovery command. And so we wanted to expand our services, and that was the focal point. How we were able to do that safely and thoughtfully, going into it, knowing at any point in time, we could then surge significantly back up again, and how would we then begin to shut services back down. So all of that really went into our thought process when we went into our recovery command. What we also wanted to do is, as we were coming back up, to implement changes that we needed to make that we were planning on doing prior to the COVID-19. So we were taking advantage of, since everything is shut down, or many things were shut down, we're going to start to put into place some of our value-added services, value-added programs, work on a length of stay, kind of like a fresh start is what our also focus was when we were in our recovery command. Now, mind you, as we were in recovery command, Froedtert Hospital, as an example, still had almost 400 patients in here a day. It did seem, we usually were running at the time prior to COVID-19 around 700 that were in our facilities every day. And so it felt like it were extremely empty, but at the same time, when you think about having 400 patients in your hospital, we were still a very, very busy hospital. So all the credit goes to the staff and our providers taking care of patients every day. So again, as we talked about going from incident command into recovery command, it's like, how do we really shift our focus? You know, inpatient and ambulatory volume and their growth, safely expand services. We also, as many institutions really did, we expanded rapidly, quickly, our whole virtual and digital platform. Virtual visits were up and running. We went from something like 38 visits over the course of a month on video or telewise to actually doing about 1,500 of those visits a day. So it was amazing work with our IT and our innovations to expand our network, expand our bandwidth in order to address all of those needs that we were seeing rapidly in that virtual world. Testing, as many of you are aware of with the COVID-19, how do you test people positively? Our laboratories did tremendous work expanding testing capabilities. We were one of the few, if not the only, in the state of Wisconsin that could actually test individuals, whether it be patients or staff, and get a result on average in less than 6 hours. And in some cases, we were able to get those testing back at about an hour and a half to 3 hours. So an amazing work by our lab team. And we started to reach out to our communities offering our testing. And it got to a point in the summer where we were doing somewhere around 27%, if not more, of all the testing that was done in the state of Wisconsin was done by labs of Froedtert Health. So again, amazing work by our laboratories. The other piece, when we looked at the recovery command that we started to see at the incident command, because again, this is a pandemic, right? And it was an emergency situation that lasted longer than 72 hours, which most do. This is now into month 2 or month 3. And so staff burnout, staff from a mental health perspective and just a support function really started to need services. We had put together prior to this a whole peer-to-peer program for our trauma area, our level 1 trauma center. We expanded those services to address all of the care providers taking care of the COVID-19 patients. As you recall, we had to use video and sort of the mental stress to have someone who was dying and not have their loved ones able to come in and see them began to really take a big toll on our providers. And so we had a rollout of our peer-to-peer program that was concentrated, as I said, on the level 1 trauma area, but we rolled that out throughout the hospital. Here are some of the dashboards that we used to monitor how we would then move up. Our N95 mask and the various different sizes, supplies, and that kind of goes in from our May timeframe to June timeframe. You can see here to the end of June. And so this is how we monitored every day what was going on in our supplies that will allow us to make the decisions we needed to make on how we would expand services again, heading back towards our recovery. Showed you earlier in a couple other slides about the incident command structure. Here was our recovery command structure. So a little different, but a lot the same. We still had our unified command. We still had our executive team. We still had our medical technical team put together, and we combined our safety office out of there. So that was shrunk a little bit. But when you look at the operational areas, it was our ambulatory and virtual care, our inpatient hospital, OR and procedural sections. Because so many people work from home, that became a whole section of how we were managing the work and the individuals that were out now working at home that were no longer on site. Our planning team was still there, and the plan for how we go back up with services versus expand bed coverage. This is about how do we turn elective surgeries back on, our ASCs back on, how do we begin to bring patients back into the ambulatory environment. So here is the absolute structure that went through it. Again, very similar to the incident command, and we operated much the same way. We met every day. We were in operating periods. Those operating periods ran from Wednesday morning to Tuesday afternoon. So sort of like a Wednesday at 7 to Wednesday at 7 the following week. And measures were put in place at whatever the plan was, had to be kind of planned out, implemented, and go within that 7-day time period. And that worked very, very well. People really enjoyed working in that structure because decisions were made quickly. All items were discussed, kind of came up through the branches, discussed at the section chiefs meeting, communicated to us at unified commanders, and then decisions were made, yes or no. So that rapid decision making turned out to allow us to do many things quickly, much faster than we had anticipated in the past. As I mentioned, our virtual visit platform and what we're going to do there, I think that was an 18-month to 24-month plan to pull that up. And we actually implemented that in 5 days. So it goes to show you that what you can do when you're really focused and all hands are on deck on the topic. And Chris, again, if there are any questions, please feel free to stop me. Any questions on the structure or what individuals have heard so far. Happy to get into some more details. There'll be some time at the end, but definitely want to entertain any questions anybody may have along the way. What this slide here kind of shows you again is what at those meetings where they were getting briefed in unified command, how that would look. So as we looked at our objective period 9, right? And here are some dates on that. Accelerate our VBC initiatives. What our VBC initiatives were, we started implementing what was called a value-based care. Value-based care included how do we reduce our cost for everything that we do inside by admission, so inside our health system. We put together some initiatives prior to, and we started to accelerate those so we were able to take full advantage of the opportunities that we had with the reduced volume. Those were some of the things discussed in like the beginning of the operational period 9, and they would carry through. And then you see another, how we would then move into operational period 10 with different objectives. So much of the things that you see there in 9, they were able to be started and finished in period 9 and move on to different objectives in period 10. It was a real rapid transition. It worked very smooth and required a lot of heavy communication, but it worked very, very well. I'll give a moment to kind of look at that slide and see all the different things in there. It was challenging, but because of the coordinated effort and the modeling behind the incident command structure, allow for this process to be very smooth and run very well. So we go from recovery, adding back elective surgeries, going into ambulatory visits, physician visits, kind of coming back up. And we ran that from May 4th all the way through to August. And in August, we decided to get back into normal operations. So we took about 3 weeks, the month of August, 3 to 4 weeks, the month of August, to go back into what we call normal operations. However, based on what we learned in the incident command, applied in recovery command, we were able to then, our normal operations would be new, different than what they were prior to COVID. So we had a different change in format with our ambulatory structure. We moved things around. We were able to watch individuals in those different branches and in the section chief lead, really lead individuals. So we got a real good assessment of what our leadership capabilities were and or were not. And then changes were made, and people were able to be either elevated into new positions or change positions because of what we were able to witness, their leadership, their skill sets in the different command structure. So when we got into going back to normal operations, we went back to a new norm going forward. And that was really a tremendous transition that went back. And even to this day, we're still transitioning. We are making a lot more rapid decision making than we needed to. Certain things that would take a year or a business planning, we realized, hey, we can do this, maybe not in a weekly basis, but within 2-week time periods. And we go from the 2-week time periods into, let's make a decision on this. It used to take a year. Now we can do it in a quarter, 90 days. And that was the mindset that we wanted to take going back into normal operations, as we call it. So we intentionally transitioned away from and use these comprehensive objectives that you see here all the way through. So we went from, operating period 8, let's expand services, and we get into 10, adding a little bit more control because access to our facilities have changed forever and what that flow was. That carried through 10 and 12. And then we wanted to, in 14, when we're getting there towards the end of the recovery, getting back into normal, is really enhance the value and operational efficiencies, reimagine what our new normal would be going into back to normal operations, as we call it. So this is sort of the mindset that we went through as we were walking through everything, assessing where we were. All along, still watching how the volume and the number of cases of COVID-19 were impacting the rest of the country, and watching where we were here in Wisconsin. So we had one eye on getting back to normal operations and another eye on watching our volume. And when we got into this, carried us through all of August, when we were in that September timeframe, we started to realize that we could handle more COVID patients in our facilities because of all the work that was done in incident command, recovery command, and now to get into normal operations. It worked really well. We had certain units in our hospital, Froedtert Hospital here, that really wanted to take on COVID patients. We had other units that was so intense that we had to give a break. We implemented mandatory respite time for individuals, again, to give them that mental break for some of the stress that they were under when we were going through all this COVID-19. So a lot of lessons learned. And we went into September really understanding, hey, we can handle a lot more volume of COVID-19 patients because of what we learned in the past.
I do see one question about that.
Sure.
How many COVID patients can Froedtert handle?
Great question. Glad you asked it. It depends, we'll say that. So as an example, today we're up to around 100. When we look at back and where we were in March and April, our peak was 83. And that peak in April, those 83 patients felt like that was 120 or 150. The 100 patients that are in our system today feels, quite honestly, just from an overall perspective, like it's about 40. Again, because of what we learned. We have plans and we can actually handle at least up to 150 COVID-19 patients before we have to, for about a week, maybe 2 weeks. And then at that point, we really have to start reducing major services in order to handle that. That reduction mainly is because of the staffing that is required for it. And we would watch our supply allocation. So as long as our supply is held up and we're able to manage the staffing, we can handle about 150 COVID-19 patients. Great question. Thank you for asking that. So we went from incident command, rolled into a recovery command structure. Our recovery command structure, you see here, then we transitioned into a reimagined, our new operation. And in our new operation structure, here's what we ended up kind of focusing on. Again, reimagined our work. We have our executive cabinet, which is made up of senior leaders in the health system. We have our operations steering committee, which was kind of now functioning as our unified command used to, but it's in this operating steering command with all the operational leaders across our system. The like what we call the entity or big section leaders. Froedtert Hospital leadership is there. Anomaly Falls leadership here, what we call our community hospital division leadership, and our ambulatory leadership division. And we're focusing on the 5 areas that you see up here: consumer guided experience, exceptional care, quality of care, business transformation, our people, our staff, and then market leadership. This is the focus. So instead of what you saw in the incident command and recovery command on ambulatory and inpatient procedural operations, that has been replaced with these focal points. And they have groups and individuals working on what our consumers experience every time they touch a Froedtert facility. Exceptional care is what we do every day. The quality of care, keeping patients, staff, family all safe, driving innovation, high-level research, all those things go into our exceptional care. Business transformation, how we do business differently, how we're going to do it quicker at lower cost. We always consistently want to work on our people and what we can do with that. Pay structures, benefit structures, leadership structures, all those things that help support our staff and providers every day. And then we look at where we are within the market leadership and how that market that we're in as Froedtert Health can expand across the state, across the region. One of the statistics that did come out, I wish I had that slide here, is our COVID-19 mortality rate was significantly below the national norms. When you look at an observed to expected ratio of 1.0, we're seeing what type of mortality that should be expected. We were actually functioning at a 0.65, which means we are way below what the rest of the country was observing in terms of mortality and sickness. We were able to handle and take care of COVID patients much better than the rest of the country had because of the staff and the providers that are here. And that information was actually out there on the Vizient website, just of how well we did and how we compared to other folks across the board. And again, that is attributable to our structure, our high level talent that we have here in terms of our medical professionals, and the coordination of effort that we had on an everyday basis, and in particular during this particular crisis.
Another question popped up.
Yep.
With the Wisconsin COVID numbers as high as they are, do you believe we may need to revert operations back to what they were in March, April, or do you think we can keep our current operations?
Again, thank you for the question. So that's and we've talked about this today, as a matter of fact. So we may need to go back, but when we go back into that sort of incident command structure, it will be different. And the reason I say that it will be different is because of the lessons learned and how well we were able to handle it. So some of the things that are different now that that wasn't then. Really, when you talk about what is happening in Wisconsin and other places, the community spread. The community spread is far more significant now than it was then, right? Because we were on a shutdown. So when the issue with the community spread isn't so much about the patients as it is the staff to take care of the patients. And so that is an area when if we would go back in incident command, is how we would look at it. Do we have the appropriate staffing levels to do what we do every day? And then how we handle the patients. Our nurses, our physicians feel that we can handle the 100 COVID patients, and that's across our system, right? When you look at that, Froedtert Hospital handling up to 700 patients and having maybe 60 or 70 of the COVID patients, we can kind of work that in and handle those patients. What we're worried about are the potential vacancies of individuals being having to be quarantined or out. Or the other aspect of this, they have to be out because their children are at home, because a school is closed due to an outbreak. That is what's different now. The regulations, what we're being held to by state regulatory agencies, federal agencies, making sure people access the facilities in a certain way where we're screening everyone, and that takes staffing. So that's the sort of things that are different. What we feel more and more comfortable about is our PPE supply. Got a great handle on that and projected that forward. How we handle the patients once they get in there, we think we have that well. When we go back, if we go back into an incident command, it'll be more along the lines of managing our staffing and keeping our doors open to everything, not wanting to shut down all of our elective surgeries like we did before. So that's how we would manage this time around versus where we were in March and April. The other thing that's a little different with this is we're going to be at this level for a while. What I mean by for a while, maybe through the end of the calendar year or through January or February. When you think of the flu and all that volume that can come up, the weather, there's different things that come with that, and the continued spread of COVID-19, that is where we're really talking about more from a staffing, how do we handle it perspective, versus the unknown of what this virus actually can do. Again, thank you very much for that question. And actually, when I think about the presentation, that's sort of coming to the end. And now I would be absolutely happy to answer even more questions about anything that I was able to kind of go through here today, or just in general about the thought process that I have here as a president, as a part of that unified command and other things.
Okay, we do have one question that popped up, and certainly an interesting one. The last speaker mentioned a number of pandemics that lasted a couple years. Is Froedtert Hospital capable of handling the personnel problems for years to come?
Great question. So when you think about those other pandemics, and again, it's a time frame. You get used to it before you get to that point where there is that immunity that comes through vaccination. So are we prepared? We are preparing. I don't think anyone is prepared for something that long, but I will tell you, we're able to hire staff, we're training staff, we're doing work differently. So when we talk about the staffing needs for virtual visits, it's a different way. We are accessing, we're providing different levels of access. So all those things are different that will allow us to carry through a year, 2 years of this type of environment that we have here. Masking sort of protocols, visitation policies, all those things that we are adjusting, that the world is adjusting to, will all go into how we manage through this pandemic, whether it takes another 12 months, 24 months, or even 36, which gets to your 1, 2, and 3 year time frame. It's still somewhat of an unknown how long we could go, but each and every day, we're learning more and more about how to handle and how to deal with this particular virus and everything that comes around it.
Thank you very much. We have a question. With the current surge suggested, are your COVID beds currently at capacity? Also, have or did you need to lay off staff, as I heard many hospitals were laying off staff? I'm thinking you probably reallocated existing staff versus laying anyone off.
Oh, thank you for the question. No, we did not have to actually lay off staff. We were changing in models of care. And in the models of care, we looked at sort of our vacancies that we have, and we may not have replaced a vacant position. There were certain services that we were contracting with that we may not have needed anymore, but there wasn't the layoffs that other health systems did. That's largely because of how we managed through our recovery command structure. We looked at and we kind of froze positions, or our leaders really were very thoughtful about hiring into, because we didn't know how we were going to deliver care a little differently. Well, we knew we had to reduce our costs and kind of make up for some things. But by doing that, there were a lot of vacant positions that we said, hey, you know what, we can do this with 3 or 4 fewer people. Therefore, those 3 vacancies that we have, we don't need to hire into. And I look at the first part of that question. If you could repeat that, Chris.
I'm sorry, repeat the first part?
Yeah.
With the current surge suggested, are your COVID beds currently at capacity?
So our COVID beds, it's a continuing flux, right? So right now we are not at COVID capacity. Froedtert Hospital, if you will, usually runs red because we're always busy. We can expand that capacity. Again, is up to an additional 100, 150 beds here. So as our COVID volume kind of fluctuates, and it's fluctuated here lately between 50 and 70, we're able to handle that that number quite normally. Again, I say that because at Froedtert Hospital, we've been used to expanding and running at capacity on normal day-to-day operations, for the past actually 5 or 6 years. So we're very comfortable in that model. We look at our capacity in our other community hospitals, and there's greater capacity at our Menominee Falls Hospital. So through greater coordination, many of our COVID beds can be moved over there, or patients can be sent to that Menominee Falls Hospital. So we're very comfortable with being able to handle more and more COVID-19 patients.
Okay, a question from Amber Ford. Are you doing anything to address staff burnout?
Yeah. So what we had in place and continue to have is what we called, and particularly in our high COVID units, mandatory respite. And so as many places do, they have the benefit of vacation time and PTO. We have that as well, but we also have been provided an additional week that you get paid. It has nothing, it doesn't come down off of your PTO bank or vacation time, extra to get rest. That has been put in place. We also have our peer-to-peer program. We have individuals actually out, particularly in areas that are called upon, but actually out talking with our employees, with our staff, and directing them to any type of support that they may need, whether that is just someone just to talk to, or more along the lines of more professional help. Those services are available to all of our staff and employees throughout the system.
All right. Can you explain why Michigan is Can you explain why Michigan is unable to use virtual visits?
No, I wish I could. I did not know that they're unable to use that. I'm wondering if it couldn't be a technology piece. Now, some of the things that was modified that we couldn't do prior to, but I thought those regulations were relaxed. You couldn't bill for a video visit prior to COVID-19, but those things were changed. So that may be some reason why they can't. I really couldn't speak to why Michigan does not or cannot use virtual visits. That's kind of surprising that they did. I had not heard that. I'll have to find that out. Again,
Do you have any other questions? We do have a question that popped up from Jill. Are any plans for redeployment of staff to assist with COVID units, as was asked in the earlier days of the pandemic?
Yes, there's a plan for that. Where in our organization, we are identifying here's the area, ambulatory and the type of clinics, if you will, that we can say, okay, here's the staff. We would go then through a training process, and then they would be redeployed. We do have a whole process for redeployment of staff to address a COVID surge, if you will, on that. And what we would do with that is we would take more of our inpatient experience skill sets that are not on the COVID unit, move them to the COVID unit. And then those individuals that are coming from outside, as they get trained up a little more, then we go to the non-COVID units. That's how we would kind of do it, kind of move our staffing around to make sure that we have the appropriate level of skill set and talent at the bedside for our COVID-19 patients. It's a changing world. I mean, we're learning, again, things each and every day. New CDC guidelines appear on their websites, and we have to keep up to date on that. I will tell you another thing that we did learn in this pandemic, and we have to do a better job of this here at Froedtert, is really staffing up our occupational health area, our occupational medicine. When we have this many in the community spread as big as it is, we have employees that are impacted. And having that area staffed up appropriately is something we never thought we would have to do, because this is a much, much, much different experience that we've never had before in our lives and our career. But that would be one of the bigger lessons learned, that, hey, staffing up our occupational health, where our employees would say, I'm not feeling well, we can send them there, I get tested and go through those protocols. We have them in place now, but that was something that was just kind of came out of the blue and caught us a little bit by surprise, as I'm sure it caught other health systems by surprise with that a little bit.
We have a question from Leah. Are you planning on utilizing the alternate care facility at State Fair Park?
Yeah, great question. So a lot of resources, a lot of planning, a lot of effort went into creating that facility there at State Fair Park. So I can tell you that in the past 7 days, we've had a list of patients that would qualify to go there to that alternate care facility. What we do is we go through, we take our case managers, have had significant conversations with the alternate care facility and plan for it and identify the patients to go. We then have to ask the patients and their families if they want to go. At least that's how we do it right now with those things. And to date, many of the families that were qualified to go there have said no to that. So as a region, we're looking at some of the criteria, and if we would continue the volume of COVID inpatients continue to rise, we would reassess how we would make an entry point or how we would direct patients to that alternate care site. But that is the one thing that's kind of been the hold up. Our processes here are very, very strong, identifying them and communicating with the alternate care site. But at the end, wanting to create that right experience, we do ask the families, and that has been sort of I don't want to say a roadblock, but sort of the things that have prevented greater utilization of the alternate care facility.
Does anybody else have any more questions?
Well, again, Chris, I think a great opportunity. Thank you so much for giving me time to kind of walk through it. Hopefully it made some sense to everyone. And thanks to all of you for everything you do every single day. I understand and know the work that you put into it and how valuable you are to everyone, the visitors, the patients, the providers, the staff, everyone, to everything you do every single day. I know it from firsthand experience as president of the hospital, but also having experience as a health unit coordinator was invaluable to me in my career. So I know what you do every day and how valuable you are. I want to thank you, all of you, for that work.
Well, thank you very much, Eric. I appreciate your time.
All right. Thank you, Chris.
You have a very, very good day.
All right.
Hey, Chris?
Hello, Greg.
Hi, Chris. So how do you want to get started? Are we getting started in a minute and a half?
Yes, we are.
Okay. So are you gonna?
Actually, I think.
Do you need to give me control here? How do we work that again? Cool. There we go.
Okay. Welcome back, everybody. I would like to present Greg Engel, Director of Planning and Preparedness at Wisconsin Emergency Management.
Okay. Good morning, everyone. I just want to verify. Can you see my slide there?
We can see it.
Excellent. Okay. Good morning. Thanks for having me here today. My name is Greg Engel, and I'm the Director of Planning and Preparedness with Wisconsin Emergency Management. I really appreciate being invited to this forum, and it was really interesting to hear the last two speakers. Just to kind of caveat what I'm going to be talking about today, I'm not a healthcare expert and I'm not a public health expert. I'm an emergency manager, and what we like to say in emergency management is we're not experts on really anything except we're experts at finding the experts. We kind of have to be a little bit expert on everything from severe weather to hazardous materials and spills and power outages, and now pandemics and emerging infectious disease, which is something I definitely was not an expert on before a few months ago. So I'm going to talk a little bit about what we've been doing at the state level, starting with kind of how we operate, give you an introduction to how emergency management works normally, how we've kind of changed things and some different things that we've done for this pandemic response. And I think it kind of should nest nicely into Eric Conley's presentation, where he was talking really about things happening right on the front lines. And I'm going to kind of share you a perspective of things maybe at the state level of how we support that. Hopefully you'll find some things interesting in there, and we'll have some chance for questions at the end. But this is really kind of an outsider's perspective to the healthcare piece of the pandemic. So just to really quickly to introduce who we are and what we do. Wisconsin Emergency Management is a state agency. We're the state's emergency management agency. We work for the governor, and we work within the Department of Military Affairs for the Adjutant General of the National Guard. But we are civilian. Our administrator is Dr. Williams, Darrell Williams. He works for the Adjutant General, but he also, under statute, reports to the governor in an emergency. So it's an interesting organization. We work really closely with the National Guard, which provides a lot of benefits because the National Guard plays a significant role in disaster response in Wisconsin and has played a huge role in supporting the pandemic response, as many of you are probably aware. So it's a great relationship. It's interesting to be working for a general, but it has a lot of benefits. Here's our mission. And I'll just highlight that what we concentrate on is building capabilities, so preparing every day of the year to increase our capability in Wisconsin, coordinating resources in support of a safe and resilient Wisconsin. And that word support is really important. We're never in charge. We are always supporting a local government or a local responder or a community partner trying to help them respond to the incident. So I kind of like to think of us in emergency management, to use a metaphor, like we're like the offensive line on a football team. We don't get our number called. We aren't the ones necessarily scoring the touchdowns, but and if we get our number called, usually it means something went wrong. But we're blocking and tackling. We're working together as a team. in order to try to do those little things and support those resource requests and do all those things needed so that the responders can do their job. And so I like this quote, emergency preparedness is a team sport, and it really is about partnerships. It's about working together at all levels, not only in government, but in the private sector, in the nonprofit arena, all the way to faith-based organizations. Everybody has a responsibility, and everybody has a role, and everybody has something to contribute to disaster preparedness. And it really isn't successful unless we're all doing our part. Another little bit about our organization. We're with the state, so we coordinate directly with the federal government through FEMA. And then our main customers at the local level are the county and tribal emergency management. We have a regional structure. We have 6 WEM regions, and we have regional staff in each one of those regions. And their job is to be those touch points with the county and tribal emergency managers to really know the local conditions and be liaisons for us out in the field. And of course, on the hospital side, Department of Health Services has HERC regions, Healthcare Emergency Response Coalition regions. And of course, they're not the same as the WEM regions. And in fact, we must have 20 to 25 different regional configurations across the state. And it does become a little bit of a problem sometimes. It can become a little confusing, something I think many of us would like to work on. But these regional structures are important, and they are ways that hospitals and other local responders can kind of share and engage in two-way communications with the state. So this whole thing kicked off for us really on March 12th when the Governor Evers issued an executive order declaring a public health emergency. So what that did was it initiated the buildup of a pretty massive state response. We activated our state emergency operations center, which you see here. This is located in Madison. And really what the state EOC is a big collaborative space for state agencies and our partners to work together to solve problems in an incident. So we had a massive staffing up of this SEOC over that first weekend. And by that following week, I think we had it was over 110 people in that EOC at one point in the first week or two. And not only was it just a lot of people, but it was a lot of people who had never set foot in there before. There were a lot of folks who, especially in the health side, who maybe were used to working with long-term care facilities, but really hadn't worked too much in the emergency preparedness field. So we were dealing with a lot of new folks. At the same time, many of our regular response agencies like the DNR and the State Patrol, they didn't have a big role in this pandemic. So it was a completely different organization, a completely different structure, a completely different dynamic than any of us were used to. So we can scale up our state EOC and our state response very quickly. We actually have 5 levels, and it starts down there at the bottom at level 5. It's our steady state where we have on-call staff 24/7 that can respond to any requests for state assistance and provide all the notifications that need to go out when an emergency happens. And from there, we can scale up. We have a level 4, which is more of a virtual operation for monitoring purposes. And then level 3 is our small scale, almost like we might call a short team that goes into the state EOC and can deal with smaller scale incidents all the way up to a level 1, which is every seat is filled and we have all the agencies in there. So it really depends on the incident severity. It depends on, are we getting a lot of resource requests to the state? Is this incident, expanding? Is it overwhelming the local government's ability to respond? Do we need massive public information? Those kinds of things. It basically scales up in order to meet whatever the needs of the incident are. And it's fairly flexible. We activated to level 1. That's what we called it. But in reality, I kind of like to call it was level COVID. It was just totally different than anything we had ever done. Like I said, we had other agencies that we hadn't really worked with before. We had Department of Workforce Development. We had Department of Children and Families. We had Department of Revenue, we had Tourism and Department of Administration, the Economic Development Agency, all sorts of these agencies that had something to contribute. They had expertise. We needed them, but they hadn't really been a part of a disaster response, and they hadn't really ever set foot in the state EOC before. So you can imagine what kind of challenge that caused for everyone. For us, because we had our processes in place, and we started to work the way we always worked, and quickly realized that wasn't going to be as effective, and we needed to adjust the way we did business. At the same time, we needed to bring folks up to speed on how we were all going to work together in this disaster. So we created some incident objectives, and these have changed over time. So this is a snapshot of some of the goals and objectives earlier in the incident, and they've changed since then. But overall, our three kind of overarching goals were to slow the spread of the virus, to try to keep the hospital bed capacity above the, or to keep the number of patients below the hospital bed capacity, because we saw it was happening in other places around the world. We saw it was happening in Italy and Spain, where, they were exceeding the local hospital capacity, and that was causing obviously serious problems. And then we wanted to make sure we were supporting and providing resources to all the different state, local healthcare and social service providers, long-term care facilities, emergency responders, so they could keep doing what they needed to do to prepare to and care for the patients. We had a lot of different objectives, a lot of different areas we were working in. Isolation facilities, trying to figure out how we would stand up and support isolation facilities, either state-led or local-led isolation capacity. Hospital surge, that's what led to the original planning and building of the State Fair Park facility, alternate care facility down in Milwaukee, but also working to try to provide guidance and planning assistance for hospitals to build up their own hospital surge plans. Specimen collection, building lab capacity. At the beginning of this, as you recall, there was a shortage of testing supplies. There was a shortage of lab capacity. So that was really a very early thing. And we set a goal of 15,000 tests per week. We've far exceeded that now, and we've actually increased that goal since then, which is, I think, a big success of this incident. Childcare was a big concern early on, trying to make sure we had childcare so that those essential workers and healthcare workers would be able to confidently be able to go to work because they had adequate childcare. Data analytics, another early need, was just trying to even understand what the data was telling us, and getting data in a format that we could consume it and our stakeholders could consume it, so we could make better decisions going forward. Contact tracing has been a big piece. It's sort of the three-legged stool of testing, contact tracing, and isolation. And the contact tracing, it's a huge staffing issue of getting staff in place so that we can do the contact tracing at all levels, at the state level and at the local level. Logistics, we set up an entire logistics section and warehouse to distribute PPE and supplies. We created a staff augmentation program, and we basically repurposed state agency staff who were at home. We put them to work as in the warehouse and as contact tracers and in other areas. We had a wildlife biologist working in the warehouse. We had grants management people doing contact tracing. It was a whole sea change for all those folks. PPE distribution, we created a bi-weekly process, and that's still ongoing, to get PPE in the hands and other supplies in the hands of the responders and the healthcare providers. Guidance and communications continues to be a huge issue, and public information. And then future operations, which really trying to plan what are things going to look like 2, 3, 4, 6 months, 1 year down the line. Here's our normal state EOC organization. It uses the incident command system model, similar to the hospital model that you just saw earlier. Pretty classic incident command system structure, and it uses something called emergency support functions. We pretty much quickly found out this model was not going to we were going to have to make some changes. We're going to have to make some adjustments in order to work in this incident. So the first real org chart for COVID-19 that we put together, and this was just a few days after the incident was the initial. The date on this is April 12th, but there were probably 10 versions of this before this. And you can tell it actually still follows the ICS model with operations, logistics, planning, and finance. But then we created these task forces on the left-hand side, and those task forces were created around many of those objectives that you saw on the other slide. So contact tracing, testing, data analytics, and then we created our logistics section, totally new kind of operation. We never ran a warehouse before. We never did inventory management, distribution management, a completely new arena for the state. Many states, like hurricane states, they're used to doing commodity distribution. Down in Florida and Texas, they distribute water, they distribute supplies. That's just not something we've ever had to do in Wisconsin. We had some plans that had been created in the past to do it, but it was just not something that had ever been a priority. There had been a lot of detailed planning around. So that was all new. So that was our first round of iterations of the organization chart. And then I'll show you the one that we ended up on by July. And you can see now ICS is gone. We ended up, we still got all the task forces, we still got all the objectives in there, but we ended up just in a completely different place. More of a long-term business, almost. We changed, it went from an emergency operation to just sort of what's the new long-term business operation for COVID. And this is the way we're still operating today. And we'll probably be operating in the future. So I think it's an interesting evolution, and it shows how, we want to have a framework like incident command system. And those frameworks are excellent, but we need to be flexible. We need to be able to make those adjustments. One of the lessons learned for me coming out of this is, is ICS the best model for an EOC? And there's actually other models out there that are starting to become more used. Like there's a resource management model that, one could argue might have been a better model for how our EOC was structured. So those are the kinds of things we're starting to explore now as the dust, I guess, has started to settle, or at least for a period of time it did. Oh, let's see here. Okay. There we go. The other thing that happens, of course, along with basically every business, is we had to learn to operate virtually. Even within the first couple of weeks, we knew we had to get people out of the state EOC. It was a risk. We wanted to increase social distancing. In those early few weeks, we needed to be working together in the same space because there was so much coordination that had to get done. But we began planning immediately for how we would go virtual. And by mid-July, we were 100% virtual, and we still are 100% virtual to this day. And even though we're ramping back up, we are having no problems operating virtually. So that's, I think, been a pretty big success as well. Something that I think every organization was forced into through COVID, and it's been a pleasant surprise, I think, how everybody has been able to adjust to remote operations. So state EOC, I like to say, does really two things. It boils down to two things. And the first is situational awareness. Situational awareness is basically, how do we understand what is happening in an incident? And in any incident, it's very difficult, especially early on, to really get a sense of, how bad is it? And we want to get not only to that awareness of what's happening, to a situational assessment, which helps us to start making decisions. What are the expected impacts? Is it getting worse? Is it getting better? How widespread is it? What resources do we need? Who else do we need to bring in to start helping us problem solve this? The state EOC is a great place for all of that to occur, because everybody's working side by side. Everybody's using the same processes, organization, the same tools. It helps us to create that situational awareness quickly during an incident. And what we say is our goal is to try to build a common operating picture. And so some people use the connect the dots metaphor. I like to use the puzzle piece metaphor. And so everybody's got a piece of the puzzle. Wisconsin Emergency Management has a piece, but other DNR I'll just put up an alphabet soup of different acronyms here. These are all the different agencies we work with, and the county emergency management, and the hospitals, and the local public health. Everybody's got a piece. Everybody's got some information, but people only have a part of that information. So what we want to do is use processes. We want to use technology, like our Web EOC system, to bring all that information together and create one whole piece, so that we're all working off the same set of assumptions and set of information so that we can make the best decisions, avoid duplicating effort, and avoid gaps. So some of the ways we do that, obviously through data. These are just some examples from this incident, is getting the data, getting it out, getting it on the website, making it as part of briefings and reports. You know, things like case counts, where the trends are going with case counts by demographics, by geography. So we've been making a lot of use of our GIS staff. And then the one on the bottom there is actually a screenshot from our Web EOC Common Operating Picture, which is a real-time system that captures all the resource requests, activity log entries, significant incidents that are happening. And you're looking at a picture of a snapshot of the National Guard specimen collection teams, the different resources requests, where they were at any particular given time. So the second thing that we do in the state EOC is coordinate resources. Probably the most important thing that we do is coordinate resources to get assistance to local government and other responders during an incident. And when you have a large incident, you have to prioritize, you have to make sure that there aren't any gaps in those requests. So we have a pretty mature process of how we like to have that work. Okay, so you have an incident that occurs, and you usually have a local incident command that gets set up, and that incident command will respond to the incident. If they need help, they might call on some neighboring jurisdictions for mutual assistance or mutual aid. If they still need additional help, they'll call the county. The county stands up the county EOC. And if the county needs help, maybe the county will call neighboring counties for mutual aid. If they still need assistance, then those requests pop up to the state. State can start actioning those, and we have mutual aid that we can reach out to other states. And as a last resort, we call on the federal government. This is the way it ideally works. It doesn't always work that way, but that connection between the local responders and the county is really key. And I was music to my ear to hear Eric Conley talk about how Froedtert was plugged into the Milwaukee UEOC, because that was exactly how it's supposed to happen. And we were distributing resources and filling requests through the county, and what we were hoping was the counties had those great connections locally. We also worked with associations and partners at the state level, and we continue to do that. There's conference calls with Wisconsin Hospital Association and all the nursing homes associations and stakeholder groups all over the place all the time. But really, it's those local connections that really make the difference. And the goal is, this graph shows basically the red line. Again, you have the little incident on the left-hand side, and that red line is the needs of the incident, the capability requirements. So it increases rapidly over a period of time, and then eventually, hopefully, decreases as the incident stabilizes and gets under control. The green resources are the local, and then it goes up through the state and the federal. The local resources are obviously the first to the incident, but they will get overwhelmed if the capability requirements get too high. So that's when the state and the federal resources come in. The goal is to try to reduce that little space between the red line and the colored blocks, because that's the gap. That's when we're not able to meet the needs of the incident. And I'll say, we've had that gap. That gap has been there during this incident, as we all know. Despite our best efforts, the capability requirements of this pandemic have been so massive and so widespread that it has been difficult. Many of our systems and processes are set up for an incident that occurs in a place. A flood might occur in a geographic location and overwhelm the local responders, and it lasts for a period of time, maybe a week, maybe 2 weeks. Well, we've had an incident that is not only a statewide incident, it's a national incident, it's a global incident, and it's lasted now for 8-9 months. So that obviously has completely challenged and stretched all of the resources and the systems that we have in place. And we've had to come up with new things on the fly in order to deal with it. Here's an example of that. This is just a snapshot of our system that tracks resources. And you can see we've had over 1,600 resource requests submitted to the state since the pandemic started back in March. And you can see how the statewide reach of those is just kind of a status tracker that showed how much was being deployed and requested and things at a given point in time. So some of the key areas that we've been working in is distribution of PPE and other supplies. You see where, this is a picture of our warehouse. And I've got updated numbers. This is just from the other day of gloves and coveralls and gowns and masks and N95s that have been distributed by the state to counties and tribes, as well as directly to providers and other state agencies throughout this incident. So it's been a massive effort. Like I said, we have a warehouse, and every day shipments are going out. We're partnering with a shipper who's just been amazing throughout this incident to keep this system going. And the demand does not stop. The demand is still there, and the supply is still tight, especially for things like gloves. We are still having trouble getting gloves, and obviously you can't do a lot without gloves. Another area of focus has been specimen collection. The National Guard stood up 25 specimen collection teams early in the incident, and we've been deploying those around the state for months. The chart just shows a weekly kind of report of the numbers of tests they completed and things like that. And this picture is at the Alliant Energy Center in Madison, which has been an ongoing site for months. I think the number is something like 627,000 specimens have been collected by the National Guard since this incident started. And it's just been, again, a partnership with the Guard, with the state, with local public health, healthcare providers. Everybody's been a part of that, making that work. Staffing is another area. I mean, we heard about it in the last presentation. I'll tell you, staffing is the area which we're seeing the biggest increase in demand right now. Early on in this incident, we thought staffing was going to be a problem back in the spring, but it wasn't. But now it is. And we have systems like Weaver, which is a volunteer registry, but Weaver was just not designed to handle the level of volume and the length of time that organizations need staff. And so it's a challenge. We just this morning, I approved a federal deployment of staff to a private hospital because we couldn't find any other way to meet those needs. So staffing is, I believe, going to continue to be a problem. And I encourage everyone to try to do everything they can to plan ahead and try to do the things that need to be done in order to meet the surge staffing needs. Staffing contracts is another area we're trying to encourage the use of. And then lastly, it was already mentioned, the alternate care facility at State Fair Park in Milwaukee stood up in the spring with about a 530 bed capacity and wasn't used. And on October 14th, we received a request from hospitals in the Fox Valley and Northeast regions to stand up the alternate care facility. So it's there, it's a resource. We've had a couple of patients there, but, and I think it was mentioned by Eric Conley. I mean, you offer it, but no one wants to go there. I mean, if you look at it, I mean, I don't know if I would want to go and spend a few days, in that place being sick. I mean, it's not ideal. It's not a hospital. And there are constraints on, what level of patients that they can accept there. And I think that's presenting a challenge as well. The other challenge is its location. When it was stood up, the highest cases in the state were in the Southeast region, but now it's in the Northeast and North Central region. So, when you talk about sending a loved one an hour and a half or 2 hours away to spend, 2 or 3 days in a facility like this, that's it's tough. So I think that it's there, and I hope that it doesn't get used. but it's there as a resource. And if things get worse, things get more desperate, then we have it. So here's where we're at, and really things are still changing quite significantly. If I had given this presentation a month ago, I probably would have highlighted different things. And in the last 3 to 4 weeks, with the numbers having the case counts and the hospitalizations going up, we're definitely not out of this. And it is hard to course correct, do make significant changes when you're in the middle of an incident, but there have been lessons learned, and we continue to learn lessons that we need to continue to work on throughout this incident. One of the things that we said right at the beginning was it's a marathon, not a sprint. And we said that and we meant it, but the difference between saying it and actually living it is harder than it looks. And I feel like we're still sprinting. We never really stopped sprinting. And with the example of the staffing, I mean, if we had known, if we could have predicted, 6 months later, back in March and October, that staffing would be in the situation, then a marathon would have been, let's put in processes in place and let's put in structures to make sure that we meet that. It's tough to do, and so we're still sprinting. I'm hopeful that we can slow down and get to marathon pace at some point, but this is a big challenge. The second lesson, I'm just going to highlight a few things. I mean, we've learned a lot of lessons. I talked about our state EOC organization and some of our processes and things like that, inventory management. I mean, there's a lot of things that we've learned, but I'm just going to talk about a few kind of high level things. And one of the things is that we forget sometimes that everyone is an emergency responder, and that is certainly true in this incident. We have had to partner with so many different agencies and responders that we never had to work with before. Childcare workers, teachers, funeral directors, dentists. All of these folks have been a part of this response, and all of them are providing some care, and they need resources. And it was totally outside of our comfort zone to work with some of these partnerships. And so we had to adjust our way of thinking a little bit. And I think on the other side, we had to make, again, outreach and education. And it's something we need to do all the time, is at outreach and education, because we don't know who is going to need to be that part of that emergency response circle for the next incident. And so all of us, whether emergency manager or whether we're one of those non-traditional responders, need to keep that in mind and need to kind of maintain that level of preparedness. And then with all those stakeholders, we need to continually plan with our stakeholders, not for them. And I think this is a lesson I think we learned early, when we stood up isolation capability and surge capability. And, we're talking about the alternate care facility is, we need to make sure we're continuously taking into account the needs out in the field and the constraints, and making sure that we're planning alongside and with people, not for them. It's hard to do, but it's something we need to do. And then I'm going to just kind of return back to the original point, that preparedness is a team sport, and we need to work together. We need to plan, we need to train, we need to exercise together. We need to recognize the different constraints, the challenges, and the mandates that we operate under. Public health has a mandate, private patient care has a different mandate, and different challenges and different constraints. And we need to recognize those things and figure out a way to adjust those things when we can in our own business model, and work with the business model of others when we can't change those things. But we kind of joked, we're not going to solve all the problems in our systems through this incident. We have to work within those systems and those constraints that we have and figure out a way to solve those problems. The only way that we do that is by planning and training and exercising together. So, it's a common axiom in emergency response that you don't want to be exchanging business cards when the house is on fire. All that preparedness, planning and training and exercising and the relationship building needs to happen before the incident. And so even though we're in the middle of an incident, it's tough to do right now. I'm just going to put in that plug for the long term and encourage everyone who's listening to make sure you're investing in preparedness every day. When the bad day hits, we're only successful if we've been preparing on the other 364 blue sky days. And that's revising our plans, it's training together, and I think most importantly, it's exercising. And if I had to choose one thing that I would do, if I could only do one thing, it would be emergency response exercises, because that forces you to come together with your partners. It forces you to work under stressful conditions, under realistic conditions. It forces you to test your plans and find the gaps and then make those improvements. The only thing I would say is we all need to try to think about how we step outside of our normal operations and challenge ourselves. And the example I'll give is, so we're great in emergency management at natural disaster, at severe weather response. I'm very proud of all the processes and systems that we have in place. And the reason that's happened is because that's where our severe disasters have come from over the last 10 years. We've activated our state EOC 16 times in the last 9 years, and 14 of those activations have been severe weather. And after every one of those severe weather activations, we do an after action review, and we come up with lessons learned, and we develop an improvement plan, and then we implement those improvements. So all those improvements we've been working on over the last 9 years have been severe weather related. None of those improvements had anything to do with emerging infectious disease or pandemic planning. So we all need to step outside of our normal operations and try to foresee what those things could be that aren't necessarily staring us right in the face. And even though we have the requirements every day to do the things that we have to do, we need to challenge ourselves to step outside and maybe go above and beyond and try to prepare for those things that aren't part of that normal requirement every day. And so that kind of concludes what I had to say today. And that's me with much shorter hair before this pandemic happened. But again, I'd be happy to answer questions. I talked a little bit about what I've experienced and what kind of topics that are interesting to me. But now I'd love to hear if there are questions about topics that you want to talk about. Let me have it.
Hello, Greg. The first question we have is from Jim. Do entities have to pay for the supplies and PPE the Wisconsin Emergency Management distributes?
No, they don't. That's an excellent question. And, it goes to, again, so many of the things that we're doing are completely unprecedented. But it was a decision made early on that we had supplies, we had donations coming in. We had supplies coming in through FEMA, and we were purchasing supplies, and all that was going into a warehouse. And the ability to try to account for that and then bill people, it would have been unmanageable. So the decision was made early on. We knew we had the major disaster declaration. We knew we had the CARES Act funding and the FEMA public assistance, that we were going to take care of the need and worry about the bills later. So no, it's all state funded.
Fantastic. I do have one question in here. If the Wisconsin Emergency Management works with hospitals, where does the Department of Health fit in?
Oh, really good question. I mean, if you kind of looked at that org chart, I didn't spend too much time on it, but the management team, and maybe I don't know if I could try to go back to a little bit. Hope this won't break the system, but the management team really of this incident has been Wisconsin Emergency Management and the Department of Health. It's kind of easier to see here. So you had a policy group up at the top, and the policy group is the governor's office and kind of leads for secretary level for DHS and Department of Military Affairs and Department of Administration. And then you had Department of Health Services, WEM, and the National Guard as sort of a three-headed management team for the state EOC. And so we just have worked hand in hand with the Department of Health. And really the Department of Health is that key. So I talked about how we want hospitals to work with county emergency management at the local level through the county EOC. At the state level, that touch point at the state EOC is with Department of Health Services. So I'm never on conference calls with hospitals or hospital association without somebody from Department of Health having set that up. I'm usually brought in to help answer questions about PPE or, the resource request process. So we work hand in hand, and really we are kind of, DHS is kind of the lead, I would say, on this incident at this point, because all of the activities, the contact tracing and the testing, they're really things that they are leading on, and we are kind of playing a supporting role to them.
Are there any more questions? All right, I think that's it then. If we have no more questions, Greg, I very much appreciate you coming to speak for us.
Well, I appreciate you having me. It was really interesting. Again, I love trying to step outside the emergency management world, and I think, we need to hear each other's perspectives more. So it was really nice to hear the hospital and the public health perspective as well.
Okay, actually, we do have one question that popped up last minute. Well, no one could predict a pandemic. How would this be different from biologic?
That's an excellent question. And I don't know if I have a good off the cuff answer for that. Again, I'm definitely not a epidemiologist or an expert. I mean, so I don't, if it were I guess is the question, if the question is whether it was an intentional biological attack, obviously that would add a significant layer in terms of working with law enforcement, working with, at the federal level, working with intelligence, and all of those aspects it would make it in many ways much more complex.
Okay. Well, thank you very much for coming.
Thanks, I appreciate it.
Yep, I hope you have a wonderful day.
The National Association of Health Unit Coordinators is grateful to Christopher Anderson and Froedtert Hospital for all the work that went into providing this excellent seminar. NAHUC is also pleased to announce that this seminar will be the first selection available in NAHUC's new virtual lending library. 3.0 NAHUC contact hours will be available to individuals who watch this seminar and submit the post-test and fee. To earn 3 NAHUC contact hours, please visit the NAHUC website and look for the Continuing Education tab. Then click on NAHUC's virtual lending library, where you will find the post-test and instructions on how to submit it. Please contact the NAHUC office if you need assistance. You can email us at office@nahuc.org, or you can call or text 815-633-4351. Thank you.